the Amjad Modi, who is from Iraq. Which country? Istanbul.
Iraq, Baghdad.
He's from Baghdad, Iraq. Baghdad was once the cultural capital where a lot of surgical inventions were made. And let's see what he tells us about his gates of heaven.
Bismillah ar-Rahman ar-Rahim. The anatomical gates of heaven as better alternative to cervical and lumbar epidurals. We've been doing these injections, the three of us, for the last 1 year. So we have a 1 year follow-up. Question is, can we have simple injections as easy as intramuscular ones that are superior to cervical and lumbar epidural ones to treat cervicobrachial pain syndrome and sciatica? The answer is yes. 4 simple injections, 2 for cervical spine disc disease and 2 for sciatica, are novel treatments for pain. No cortisone is needed, no X-ray, no nerve device, no ultrasound, and no theater setting. Gate A is an injection in the bicipital groove of the humerus that will make the pain go in only 3 minutes. So before finishing putting the buttons of his shirt or clothes, he'll be out of pain completely. Gate B is a simple carpal tunnel injection. It will take around half an hour to work. So you do the injection and you make the patient wait for half an hour. So A and B for any nerve-related pain in the upper arm, including tennis elbow. Gate C and Gate D are for sciatica and lower back pain. Gate C is simple tarsal tunnel injection. I can say that more than 95% of orthopedic doctors never injected there in the tarsal tunnel. I don't know, it's like a vague spot. Carpal tunnel we do, but tarsal tunnel, most of us never done it before. And Gate D is another injection for sciatica. It is in the upper tibiofibular joint. So how do we define an anatomical gate? It is an anatomical gate is a space in which lignocaine injection can be done without ultrasound or nerve stimulator, machine guidance, or X-ray. It can be verified successful by clinical numbness in specific dermatomes, the 3.5 of the median nerve, and heel numbness in tarsal tunnel. So you give the injection. If you have numbness in the fingers, it means you injected inside the carpal tunnel within 5 minutes. You wait another 25 minutes, and then he will have decreasing pain in the upper limb. In the tarsal tunnel, you should have heel numbness, or you have substantial relief of pain within 5 minutes of injection, like in Gate A in the axilla and Gate D here. The pain relief will last from 1 week to 1 year, and success rate is equaling or surpassing epidurals. Most difficult problems have the most simple solutions. This is the irony. And this is a very important thing to me. It touched my heart when I first read it. It is not important where you are, but it is important what you do. I was working in the UK. I stayed there for 11 years. And, not all people get the training job. And there is a lot of sadness that I'm not getting into training and all these things. But it is not important. I'm now making more money than in the UK. Nobody is bullying me, and I am the boss. So, with all the respect to Dr. Gore, the 3 of us were oblivious to his diagnostic technique. So, what brought about the discovery? Dr. Diavakar posted on Facebook that a tennis elbow can be cured by an injection in there. He called it later on J-gate. When I first saw the post on Facebook, I couldn't believe it, so I didn't try it. 3-4 months later, he again reposted the same thing. So I said, why not try it? We have tennis elbow, golfer elbow, carpal tunnel syndrome. Could the cause of pain be the cervical spine?
Can you show the previous slide?
This one?
Yes, yes.
Yes. So Dr. Divakar injected here in the first swab space, and he had relief of tennis elbow. He was very fearful not to say that tennis elbow is of nerve origin, and I couldn't post anything, but I was encouraged when Dr. Prakash broke the silence. So we have tennis elbow, golfer's elbow, carpal tunnel syndrome. Could the cause of these be related to the cervical spine? Well, there are some hints. I can't say yes or no. I prefer myself, I say yes. So in this study, tennis elbow on the cervical spine, there are patients who failed treatment directed towards the elbow, whilst they responded to treatment directed to the cervical spine. 50 patients of tennis elbow responded to treatment directed to the cervical spine after 4 failed weeks of treatment directed to the elbow. So that's a big hint. Now, golfer's elbow. People with the diagnosis of medial epicondylitis, people with the 102 patients diagnosed with cervical radiculopathy were examined for medial epicondylitis. More than half had medial epicondylitis. So they are related, like tennis elbow. Now, carpal tunnel. 43 patients with idiopathic carpal tunnel syndrome confined by nerve conduction study and treated by surgery were compared clinically with 43 age and 6 match control patients. Patients with carpal tunnel syndrome had a significantly greater prevalence of lateral humeral epicondylitis. So 3 things, and we come to the could all be related to nerve problem: tennis elbow, golfers, tennis, and could the carpal tunnel itself, the carpal tunnel first operation started, I think, 1944 or 1954. So could the carpal tunnel pain be actually caused by the problem in the cervical spine? So there is a potential paper, tennis elbow. A comparison study could be done between local elbow injections and lignocaine carpal tunnel injection. Just lignocaine instead of the carpal tunnel. I'm sure the success rate would be towards the carpal tunnel injection. Again, what brought about the discovery? This is Dr. Divakar called this spot gate J. This is when the thing began. He tried it with tennis elbow. When he published that on Facebook, it made me think, how is the pain is being relieved up? So there is no answer. It must be through nerves. So I thought of nerves like rivers that are going both ways. And then I said, why use a small nerve, superficial pinhole? Why not use the median nerve? It's bigger. I believe that the conveyor of the injected chemical is the myelin sheath, which is a fatty covering. It's more than 90%, it's fat. Dr. Gore talked about that nobody talks about chemical cause of the pain in the back. Actually, this injection will prove that it is neither mechanical or chemical. It's just the nerves are too excited by the first trauma. So nerves are like high power electrical cables, very sensitive like this pretty woman. When slapped, they go hysterical, fumingly angry. Calm them down with lidocaine, like hugging an angry woman. They will behave. Lidocaine acts only for 1 hour, maximum 2 hours. But with these injections, they are lasting for 1 year. Dr. Mukherjee in Jaipur said that radicopathy is an allergic reaction. There are lots of evidence that it is not mechanical. First, failure rate of dissectomy. Lots of people fail the operation. Like if you ask 10 patients of yours who had the conventional dissectomy or the ORF ones with the screws, maybe 1 or 2 maximum, they say we are all okay. 8 of them, they still have the pain. And come back in 5 to 10 years, ask the 2 patients who said they were well, the pain will come back. And I thank Dr. Prakash. Without him, I didn't know the story of the disc disease. He sent me a book all about disc disease. I read it, and I saw all the evidence he put that it is, with the references being made by the big surgeons of the back, that it is actually not a successful operation. And there are some evidence, Kelly, who felt that if it is really a pressure, patient should have paralysis, not pain. But they are not having paralysis, very small percentage. And there is a study, 48 patients, they were injected only placebo, only water for injection, and they had pain relief. So again, the anatomical gates of heaven, gate A, 3 minutes. Grade D, 3 minutes as well, and we have B and C. Gate A is in the axilla bicipital groove above the axillary artery. I'll put a video at the end. Gate B is just simple carpal tunnel injection, which I cannot manage, to be honest with you, these days. I don't get the fingers now for one reason or another. Gate A and B for upper limb neurological pain. A, 3 minutes, B, half an hour. Gate C is tarsal tunnel injection. So we have A here, B here, and then C, D. And gate T is upper tibiofemoral joint, 10 mil. 10 mil by definition. So for cervical brachial pain syndrome of any severity, because when we come to sciatica, there are 2, C and D, they differ. But here, any severity, A and B will work. A within 3 minutes, B within half an hour. Whilst here, gate C is more towards pain of VAS score below 7. If you have somebody coming to you, walking like that, he will not respond to it, in my experience. So his pain needs to be chronic or below 7 in severity. Gate D is the one that works for severe pain. And in my experience, I've been doing caudal epidural in my clinic. Some patients failed the caudal epidural. They responded to gate D injection. Gate D, 3 minutes only to work. This is put some rules. Those patients who had any surgical intervention in their back respond much less preferably than those who had their backs not touched by surgeons. This rule includes lumbar epidurals, gate D and gate C injection. And even when I was trying to give caudal epidural to those who had operations, I find it difficult to push the fluid inside. Second rule, gate C or gate D, which one to choose? Acute severe pain, we said it is gate D, knee. Gate C injection, it is for chronic pain, VAS score below 7, any patient with a previous surgery on the spine. And to make things simple, just do both of them. Rule number 3, gate A and B injection. If you have no pain relief after gate A or gate B injection, look for other cause of neck pain. Like most common thing is chronic sternocleidomastoid muscles spasm. Chronic when it is more than 3 months. They will not respond to medications. The only cure for such cases, again from Dr. Prakash, nice book, injection book, is to inject only lignocaine in that tender muscle. So if you have any chronic muscle pain, just inject it with xylocaine. It will act as a cure. Some people in nearby country, they inject Botox, which is $500 expensive. I don't know whether it works or not. Rule number 4, if you have pain relief that lasts less than 24 hours after 2 successive injections, do not give a third injection. Do extensive investigation. You might have an infection or carcinoma in a perfectly looking young patient. I saw a young patient perfectly looking normal. She had something like an infection in the spine. So if you give one injection, it doesn't work, repeat it. If they come for the third one and the effect didn't last one day, then do extensive investigations. I don't do normally the investigations. I just give the injection depending on the history. Cervical brachial pain syndrome or pain related to the cervical spine. This is usually a territory of a neurosurgeon. Most of us are oblivious to it. So in the next slides, you will know what it is, how you are going to diagnose, and when to worry, when to refer. So neck pain associated with tingling, numbness, or discomfort in the arm, upper back, and upper chest, with or without associated headache, is considered as cervical pain syndrome. So pain in the head, neck, anywhere in the upper limb. And I put this picture specifically because Dr. Gore as well said that this is not fibromyalgia. This is pain related to the cervical spine in that exact spot, medial part of the scapula. And of course, they will have some sort of vertigo in some of them. The most important thing in diagnosis is history. You know what it is. You've seen patients. If you haven't seen patients, it's difficult to diagnose. So you ask about the pain, constitutive, all these things. And any recent dental procedure is very important, especially if there was a decay, because you can have an abscess, retropharyngeal abscess. Family history, and of course you need to ask about lower back pain. These are the signs when you need to worry, when you need to refer the patient to a neurosurgeon. Symptoms of myelopathy. I haven't seen a patient till now for the last 1 year having these things. So difficulty in moving the arms or legs, you refer. Trouble with coordination or balance. You don't need to refer really if you have this thing. You can give the injection, and if the vertigo and the balance is okay, then you're okay. Loss of bowel and bladder control, refer the patient to the neurosurgeon. Weakness or numbness anywhere beneath the neck, you refer. Shock-like pains through the arms or leg, which can be made worse by bending forward. Again, in this, you can try the injection first. If you have it happened with me, 2 successive gate A or gate B injection with less than 24 hours pain relief, then there is something serious going on. Examination, again, the gait, all the normal things. There are lots of neurologic examination. The most important thing, I think, is cervical spine, sternocleidomastoid, we said important, and shoulders. Now we come to investigations. There is X-ray, MRI, and nerve conduction studies. MRI, in 50% of early 20s people, they will have MRI changes. And this percentage jump into 90% if they are over the age of 50. So, people who are perfectly well, they have no symptoms at all, you will have MRI changes. So you cannot rely really 100% on the MRI. The most important thing is the history. These are the injection, which I don't worry about the names because I think they will go obsolete. These are the cervical epidural injections. Their success rate is around 63%. Those patients who are fit for surgery because they didn't respond to conservative management of the cervical spine disease, they offered them injection and the success rate was 63%. Benefit lasted around 1 year. More favorable response on patients over 50, more favorable response on those treated within 20 days of diagnosis, an early injection. But we have really serious complications of the cervical epidural ones, really serious, more serious than the lumbar epidurals. This is the study you've done, pain in the neck, radiating to one or both arms. None had any neurological finding in terms of sensory or motor deficits. 24 patients, age 21 to 63. Period duration is variable. We gave only lignocaine. The success rate was 91 successful at 3 months, 45 successful at 6 months. What are the applications of these injections? Gate A and B injection for the upper limb are much safer, cheaper, and more successful. If you do a bit of calculation, 27,000 operations per year can be prevented on the cervical spine in the USA alone. 600,000 operations on the neck can be prevented annually, worldwide. These are the operations which are what they do for the cervical spine, just to have an idea. ACDF, PCDF, and now they have the disc arthroplasty. And the indication most of the time is pain. Look, artificial disc replacement surgery, also known as total disc arthroplasty or total disc replacement, indicated in cervical disc herniation that's causing significant neck pain or arm pain. No response to non-surgical treatment, only for 6 weeks. Patient not responding, there is an excuse to take him to theater. So the indications of operation are almost always pain. And these are the arthroplasty thing. The difference between them and the ACDF and PC, and between them and the plates. The ACDA group had significantly better neurological outcomes, significantly lower rate of adjacent segment disease, because when you do the screws and the plate, you'll have osteoarthritis above and below. These are the costs in the USA of these operations. This is the ACDF scar, just to show you. This is the success rate of the ACDF operation, 85 to 95. Additional surgery for pseudoarthrosis is 10%, and then additional surgery, so it will build up. And it is more successful in relieving arm pain rather than the neck pain. So a neck collar should become obsolete from now on, because in the West they offer you the injection after 4 weeks of failed treatment. Now you can have simple carpal tunnel injection, and there is no need to wear this collar. All these medications, tramadol, gabapentin, there is no need to them really anymore. These are the other things which should be effective I believe in them in treating the nerve pain. TENS machine. The problem is some of the doctors advise putting the electrodes on the neck or on the back. No, they work better if you put them in the limbs. Like here he's putting it over the axillary artery territory. These things, they work as well, because they are exciting the superficial nerve, and then possibly some chemical is ascending through the nerves. I give also folic acid and cyanocobalamin to patients. There is a lot of literature about resveratrol, which is related to diet, which diet you give in patients with the nerve problems. So it's mainly present in red raisins, lots of literature on it. And these are the foods that contain resveratrol. We leave this thing. Tarsal tunnel injection. This is how I do it. There is a video about it. More than 95% of orthopedic doctors never injected there. So these are the anatomical contents of the tarsal tunnel. There is a way to remember them, though it's a bit naughty. So, tarsal tunnel injection, gate C, which is in the foot, it is helpful in lower back pain with or without sciatica, disc disease, moderate severity, VAS score below 7, lower back pain related to listhesis, metastatic lumbar spine. I had a patient, I can't remember where she had the primary cancer, but she had metastasis to the lumbar spine. I gave her an injection, she was pain-free for 3 months. She came later on for another injection, but the second one didn't work. Nocturnal calf muscles cramp. This is the thing that they give quinine for it. Diabetic neuropathy. And this is very important thing. To make the heel knob for plantar fasciitis injection, some tremors of the lower limb. It works for some tremors as well. I'll show the video. And the heel, if you are adamant on giving an injection in the heel, it's very painful. So by giving the tarsal tunnel injection, the heel will go numb, and then you can give the injection in the plantar fascia safely. I will disclose a secret encouraged by Dr. Gore. Heel pain, there is something called plantar fasciitis. It exists, but its percentage is around 5%, probably 10 maximum. 90% of the pain is relieved by you give injection there. So if you have any patient with heel pain, most of the doctors will diagnose it as plantar fasciitis. You give an injection there. I used to give cortisone with it. 95% success rate. You will not see them again. Nowadays, I'm starting giving only xylocaine without steroids. So heel pain, 95%, it is a nerve pain. And the way you can differentiate it between it and plantar fasciitis is few things. Don't look on X-ray. The spot on the X-ray, whether present or not, it doesn't make any. Usually patients with the nerve pain, the pain is in the middle of the heel. Whilst plantar fasciitis, it's medially. This is one thing. Secondly, people with nerve pain in the heel, usually they have hyper dorsiflexion of the ankle. You might get amazed, you might get 35%. Not all of them, but a big percentage of them. Second thing is the description of pain. Plantar fasciitis, he will tell you there's a sharp pain, like a knife, a piece of a glass. When he's waking up and he put the first foot on the floor. Whilst the nerve pain, he will say it's all painful, dull pain. Okay? And plantar fasciitis pain, when he walks a distance, after a few steps, he's okay. Whilst the nerve pain, if he walks a long distance, the pain will be there. So this is how to differentiate between them. Purely history and clinical examination. This is an adrenaline ampoule inside a syringe, very handy to use. There is very low incidence of anaphylactic reaction to xylocaine, but at least maybe 1 in a million. But be careful, put it there just in case. These are the traditional ways of treating sciatica back home. They either do the cup therapy, the wet one, or they do burning of the skin and venesection. We used to laugh on them on college and say this, but actually the way they are working is by stimulating the superficial nerves. So we have to respect tradition. There is a secret down there. This is gate A injection. It will show you the technique, and it is self-explanatory with some subtitles. You don't need to worry about filming them. It will be on YouTube. You feel the bone as if you want to pass a wire off, a laser off. When I began, I used to feel the artery. Now I don't need to feel the artery because I know the spot. I just put the things down with my finger and then go straight into the bone. Just make the needle touch the bone. That's all. Don't go above or below. If you go above or below, just repeat. Take it out and make the needle touch the bone in the bicipital groove. Once you touch it, just withdraw a few millimeters, just enough to inject. I'm injecting now cortisone with xylocaine. I don't do it anymore. Only xylocaine will do. One in the 1% of patients might describe the upper arm is gum paralysis, not moving, but the next day it will be fine. Usually by a woman, so maybe they are lying, I don't know, exaggerating things. This is gate D injection. This is really magical one. It works for severe pain. This is the one you need if you have somebody coming to you, bending to one side or shouting out of pain. And in my small experience with it, because I began with it in the last maybe 2 months, it has succeeded when epidural one failed. The nerve is quite far away. Upper part of the tibia, and this is the fibula behind. You feel the skin. There is just like a dip. Your finger will feel a dip.
Until there is like a dip. Just down here, you feel like a dip. Bismillah ar-Rahman ar-Rahim. You go there, needle in.
And then you inject. Most of the time it will not go as smooth as this. It will go slowly, really resistant injection. This is tarsal tunnel injection. This is how I do it.
This is the medial malleolus. You go posterior. Once you feel the dip that you are on the periphery of the medial malleolus, this is the spot. This is how I go. This is the inclination of the needle. شوي ارجع لورا حتى يشوف النيدل شلون مالتها الزاوية. من بعيد سوي هيجي. This is how I go.
And it is better because you have a lot of volume to go like that, in, out, so that you make sure on your way going in and out, you are in the tunnel. You should have heel numbness within 5 minutes. If there is no heel numbness, just the toes, it might not work. This is a patient with left side sciatica, 6 months, unable to stand on left leg. When I asked him to stand on your left leg, he was couldn't. He was trying to touch the chair. The most successful injection is when you can get the whole needle inside. There is a spot. Here I'm not getting, here, see, the whole needle is in. Only less than 5 minutes. He's standing on his left leg. He couldn't before the injection. And he's got normal gait. I'll show you this interesting thing. This is Parkinson's, 6 years. And after the injection, she's okay. I'm not saying it works with all the tremors. It doesn't. And this lady, I haven't seen her. This gentleman, he came to me 3 months after the injection, and he was still tremorless, without tremor. Look how he's shaking his legs. This one. So. This is the last book Dr. Prakash enticed me to read, because he put a enticing paragraph before it. The story of orthopedics. So it says, why are we not more creative? It is easy to regard Charlie or Lister or Fleming as a genius, as if that explained everything. But why doesn't everyone come up with a good idea? Why did it take so long? Because orthopedics, if a patient comes 150 years ago, any knee pain is TB. They don't know about osteoarthritis or anything else. So the writer says, I think the reason is that we are sheep much of the time. No one wants to be first. We all attend seminars so that we will fill our heads with the ideas of other people. So take home message, try not to be a sheep. Thank you very much indeed.